Good evening, and thank you for joining us for our pediatric health talk on seizures and spells in babies and children. What to look for, when to see a pediatric neurologist, and what questions to ask at the appointment. A couple of housekeeping notes before we begin. In this platform, all attendees are muted. While you won't be able to ask questions audibly, please note the QA feature on your screen. If you have a question that is not addressed during the presentation, please feel free to submit it through the QA feature, and we will address as many as possible before the end of our session today. Also, today's seminar is being recorded and will be posted on our website. As a registrant of today's session, you will receive an email with the link once it's live. Please allow at least 1 week for post-production work before you will receive this email. It's now my pleasure to introduce our presenter for this session. We are very fortunate tonight to hear from an expert in pediatric seizures. Dr. Jennifer Waldron is a pediatric neurologist who specializes in diagnosing and treating babies, children, teens experiencing seizures or those who have epilepsy. Dr. Waldron completed fellowships in both pediatric neurology and also in epilepsy and EEG. She's also an assistant professor at Case Western Reserve University School of Medicine. Now I'll turn it over to Dr. Waldron to start our session tonight. Dr. Waldron?
Hi, Tia. Thank you. It's a pleasure to be here talking with everyone this evening. So I'm going to start by sort of an introduction. I appreciate the introduction, but I would like to just say that this is by no means a comprehensive talk on seizures or epilepsy. This is really an introduction and some things as a caregiver to look for in your children and what to do if your child has a seizure or maybe having seizures or is having other episodes of uncertainty. The first thing is always to make sure your child is safe and also to talk about that with your primary care provider. So we'll start with some definitions. First of all, what is a seizure? Seizures are abnormal electrical and chemical changes in the brain that cause sudden changes in physical movements, sensations, behaviors, and also levels of consciousness. And seizures can look very different. They can look different from each other. They can look different in children than adults. They can look different in infants and children. And it's important that we recognize that they can also look like things that are not seizures. And that's what part of this talk is, to try to help us understand the features that make us more concerned that it could be a seizure. We think about seizures as sort of in two categories. Generalized seizures are seizures that involve both hemispheres of the brain, and it's a diffuse seizure. So the electrical and chemical abnormalities are broad and they go through both sides of the brain. These seizures are associated with typically a loss of consciousness to some extent, but they can also look different. So I'd say the most common seizure type that people are familiar with is a generalized seizure, and it's called a generalized tonic-clonic seizure. This is a seizure that, when you think about like a seizure you might see on TV, it's where the whole body stiffens. That's the tonic component, and then the whole body shakes in a rhythmic way. These seizures typically last about 1 to 3 minutes, and they usually stop on their own. Patients, their eyes may be open, but they're not responsive. They aren't able to hear you. They won't remember having the seizure typically. And they may lose control of their bladder. They may have a lot of secretions coming from their mouth. Eyes are typically open, and families will often describe that the eyes sort of look like they're up or back or rolled back. And these seizures are very distressing for families and caregivers. They're scary. They're not subtle. When a child has a first one of these, often 911 is called very appropriately. And after it's over, the child will be very tired and sleepy, and that can, it may take them up like 10, 15 minutes up to hours to sort of come back to themselves after a big generalized tonic-clonic seizure. Another type of generalized seizure that is also quite common and is part of a form of childhood epilepsy is an absence seizure. And this looks very, very, very different than a generalized tonic-clonic seizure, even though it is still a process involving both sides of the brain and the diffuse brain. And that is an absence seizure. And an absence seizure can be, on the contrary, quite subtle, and that a child may just look like they're daydreaming, or they may just pause for a second in what they're doing. They may kind of blink their eyes a few times, and while they aren't actually present for a few seconds, these seizures usually last about 5 to 15 seconds. They'll go right about what they were doing before most of the time. And so this is a type of seizure that often takes a long time for parents, caregivers, doctors, and often teachers to sort of identify and recognize. Another type of seizure and a different type of seizure is a focal seizure. And a focal seizure is when the chemical and electrical discharge is specific to one area of the brain. And as you can see on my slide here, this is a picture of half of a brain, and you can see the different lobes of the brain. And if a signal, and if an electrical discharge starts in one area and spreads in that area, the seizure may look very different. And these can also spread quickly and rapidly and go throughout the whole brain. And the patient may not be oriented, they may fall down, they may shake, or they may just look confused for a minute, or they may turn in a circle, or they may describe feeling an unusual sensation, or a feeling of panic, or even a feeling of I've been here before. There may also be movements that don't look rhythmic or stiff or shaking, and may just look like an unusual pattern of fumbling with your hands or moving your mouth in a certain way. So these can also be quite subtle, or they can also look quite large and scary. So seizures can, I think the take-home message here is that seizures can be very big and scary and clear, and you know this what it is. Other times they can be very subtle. So again, what a seizure may look like, maybe a loss or a sudden change in level of consciousness. A convulsion is what we say when a person shakes or has shaking of their body, staring episodes, a feeling of panic or a feeling of fear or a feeling of an experience. I will say that young children and often have a very hard time describing that sensation or a sensation. They may not recognize it, but families sometimes will say, oh, before the seizure, they get a look of fear, or before a seizure, they complain of a stomach ache, or they sit down. Sometimes after a person has a seizure, they don't recall having that unusual sensation, but the family or caregiver will recognize that there's something that's sort of happening first. Again, sudden stiffening, jerking, either of the diffuse body or just one side of the body or one limb of the body. It can be as simple as a head drop or a head nod. Sometimes kids will just have seizures where they just fall. And again, when you're getting that story of a kid just falling, I mean, kids fall all the time, right? Like toddlers trip all the time. It's really truly a fall for no reason. As well as other sort of episodes where children can do funny movements or waken out of sleep, which again, like children often do funny movements and wake out of sleep. So it can be very hard to tell. And that's why if you have any concern of one of the things about seizures is they tend to happen like over again. So if it's a subtle seizure, it may be that you're seeing a pattern emerge over time. So I'm going to talk now about another definition, and that is, what is epilepsy? So not everybody who has a seizure has epilepsy. Anyone can have a seizure. A seizure can be triggered by an injury to the brain, a stroke, an infection around the brain, such as meningitis, or ingesting some sort of toxic substance, or certain medications can certainly make it more prone to have seizures. So having a seizure in the context of something that's acutely causing that seizure is not epilepsy. Epilepsy is a tendency towards seizures without those variables. So it's a person who has 2 or more seizures, at least 24 hours apart. So sort of 2 separate incidences of seizures without one of those known variables or known triggers for seizures. And epilepsy is the most common neurological disorder of childhood. It is common. It affects 1% of the population, and including children. About 2/3 of children with epilepsy will have their seizures resolved by adulthood. However, there are other children who will develop seizures who may have hard to control seizures or may have seizures in the context of other developmental and neurological conditions. And there are people who will require treatment for epilepsy throughout their lifetime. Epilepsy may have a known cause, and these causes can be different for different patients. Sometimes a remote injury, an injury to the brain during development or during birth, or that happened in childhood, will then later go on to develop seizures from that area. Malformations of the brain, there can be genetic causes or genetic predispositions. Sometimes certain types of epilepsies run in families. But I will say many people with epilepsy do not have a known cause for their epilepsy. So now we can talk about how epilepsy is diagnosed. First, any child who has a seizure without a known diagnosis of epilepsy or prior history of seizures does require immediate medical care. And epilepsy, again, is a clinical diagnosis. It's not like there's one single blood test that you run and you diagnose epilepsy, or one test that will diagnose epilepsy. It's sort of putting all the pieces together for the child and for what's going on for that child. The first thing we start out with is a detailed medical history. And when I'm taking a medical history for my patients, I go all the way back. I go to the birth history, the prenatal history, the history of the pregnancy, the mother's health during the pregnancy. I want to hear about all the development of the milestones, whether the child has ever had a history of any sort of trauma to their head, concussions, recent infections, whether they've had other sort of spells, like such as fainting. In retrospect, if there have been other things where maybe they've lost consciousness that look different than what maybe the presenting episode was that they came in with. But you really want to know any medications that the patient's on, and any sort of recent or remote changes. You want to get a detailed description of the seizure or the seizure-like event from a firsthand witness, and that's really important. So if a seizure happens at school, it's really important that we talk to the person who saw it, whether it's a teacher or a principal. That's not always possible, but we really try. Another thing that can be helpful based on that detailed description and seeing what the seizure or seizure-like event looks like, if it's something that's happening and it's subtle and it's repetitive, I always say a picture is worth 1,000 words, a video is worth like 10,000 words. So if a family sees a child doing something sort of funny in sleep, or funny, a movement at home that's repetitive, or if they're staring, it's very helpful if they can take it, and the child is safe and stable, if they can take a quick video on their cell phone. Part of the diagnosis is doing a detailed physical exam, a detailed neurological exam, a detailed developmental history. We do blood tests. We often look for signs of infection, signs of abnormalities in electrolytes or other metabolic markers related to the kidneys or the liver. We often, after a child has a first-time seizure, or if we're working up a diagnosis of potential epilepsy, is get a picture of the brain. There's three actually. So head ultrasound, which we'll talk about a little bit more, is something we can do in newborns. That's a very limited view of the brain. A CT scan is a good picture, and this is often what is done in emergency departments. And this can rule out big problems: blood, trauma, a large stroke, a tumor. But it's not really the best picture of the brain. The best picture of the brain is an MRI. And an MRI, I always sort of say, if a CT is like a grainy black and white TV screen, an MRI is kind of like the high def picture. So an MRI really can show you the detailed anatomy of the brain. It can show you the bends and folds, how the brain formed, and if there's any subtle changes that may put a patient at risk for having seizures. Many, many times in epilepsy and in seizures, isolated seizures, the MRI and the CT scan are completely normal. But it is something we like to always get a picture to make sure we're not missing an underlying problem or a new big problem. An EEG is another very potentially very helpful test. I'm going to talk about that more on my next slide. So an EEG stands for electroencephalogram, and this is a test that looks at the electrical brain waves and patterns. This is a test that is not painful. It doesn't involve any needles, but kids don't like it. It does involve gluing a bunch of sort of metal stickers all over the brain, all over the scalp of the head, I should say, not the brain. There's nothing invasive about this test. The test itself, we tend to do a routine EEG, is about 30 to 60 minutes, but we sometimes will do a longer EEG with a video, and that we can do up to like 1 to 3 days. And depending on the scenario, we decide which one of these, how long in the EEG should take. What we're looking at on the EEG is brain waves, and we're looking first to see, is the pattern of brain wave what we'd expect to see, what we expect for the child's age. And brain waves look different between different ages. Like a newborn's EEG pattern looks very different than a 16-year-old's EEG pattern versus an 80-year-old's EEG pattern. They do look different in different time periods of life. We're looking to see, are the patterns normal? It's helpful to see if the child is awake and asleep, if it looks what we'd expect in awake and asleep as well. We also like to look and see, are the two hemispheres, the two sides of the brain, do they look the same? Are they symmetric? Is there anything slower on the right side versus the left side? Or are the waves higher on one side than the other side? That can be a clue. We're also looking to see, are there markers for epilepsy, or are there markers that there may be an increased risk for seizures? And we call these sharp waves or spike waves. And these can have a very specific pattern for certain types of epilepsy. Again, these can be generalized, showing it's like a diffuse discharge throughout the brain, or it can be very focal in one area of the brain. But when we see that, that's a very helpful clue to us that this patient or this child may have a tendency towards seizures, or be at increased risk for seizures. I will also say sometimes people have epilepsy and their EEG is very normal. It's completely normal. And unless you actually record the seizure itself, you don't actually see any changes on the EEG. So again, it's a helpful test. If it shows us something, it's very helpful. If it doesn't show us something, it may not necessarily mean that there isn't epilepsy or a tendency towards seizures. And that's, again, when I go back to epilepsy, it's a clinical diagnosis. It's putting all these pieces together, putting the history of the child together, the history of what the family is reporting and seeing. And again, if things become very unclear, or if the child's having a lot of episodes, or we really don't know if they are seizures or not, one very helpful tool we have is to do a long EEG, like over several days in our epilepsy monitoring unit. And that, the more we record, the more data we get, the more we can definitively answer the question, are these not seizures? So treatment options. So once epilepsy is diagnosed, again, we do our best to assess the type of seizures based on the history, the description, home videos, and EEGs. And we work to identify an underlying cause, which we may or may not find. But based on all those pieces, we decide what the best medication is. So the first line treatment for epilepsy is anti-seizure medications. And there are many types of anti-seizure medications, and certain anti-seizure medications may be better for a certain type of seizure or epilepsy than others. And we also always count. Another variable would be like, what do we think the patient will best tolerate, or how old is the patient? Potential side effects or potential interactions with other medications the child may be on. Other treatments we sometimes consider our diet. And this is something that we use when a child is having hard to control seizures on medications, or if they have a specific type of epilepsy that responds to the ketogenic diet. Surgery may be an option for children with focal epilepsy that are hard to control, with seizures hard to control on medications. And there are other medical devices such as vagal nerve stimulators that we sometimes consider. When a child is diagnosed with epilepsy, they will continue to be followed with their primary care provider, and they will also be followed by a child neurologist or a child epileptologist. A child neurologist is a doctor who has training in both pediatrics and neurology. And neurology really is the study of neurological disorders, disorders involving the brain, the spinal cord, the muscles, and the nerves. And an epileptologist is a neurologist with additional training in epilepsy and reading EEGs and epilepsy surgery, and often is involved in treatment of hard to control seizures and epilepsy. So what are the risks to a child with epilepsy? I'd say my biggest concern for my patients is injury. There's also the risk of a seizure that is very long and can be difficult to stop. And if a seizure lasts longer than 30 minutes, it is called status epilepticus. And this is a medical emergency and does require usually a lot of intervention to stop the seizures, a lot of medications, and being in the hospital, often being in an ICU setting. This is rare. The vast majority of seizures do stop on their own or stop within 1 to 2 to even, to 3 minutes. And we do give families whose children have had seizures and who have a diagnosis of epilepsy a plan of what to do if your child at home, if your child is having a prolonged seizure. And I'll talk about that more on the next slide. So how can the risks of seizures be minimized? So again, I worry a lot about injury for my patients. I think the by far biggest risk of seizures is having a seizure in a place that's dangerous to have a seizure. So I think about swimming pools and bathtubs and even little kiddie pools in the yard. Drowning, you're not conscious when you're having a seizure, so drowning can happen. So I always advise my patients and their caregivers to have very, very close one-on-one supervision around water. Motorized toys, cars for teenagers. These are all things that we take very seriously as a risk to the child as well as others. So, driving a lawnmower or driving an ATV, if a child does not have well-controlled seizures, they should not be playing with those specific toys. We sometimes will, I tend to try not to restrict my patients' activities. I just like to say, do things with extra caution, unless they really are having frequent seizures. I may restrict heights or certain sports. The biggest way in a child with epilepsy to prevent seizures is to take the anti-seizure medications as prescribed. And so most anti-seizure medications are dosed twice daily. Most of them come in a liquid formulation for younger children. But taking the dose twice a day, same time of day, taking as soon as possible if you do happen to forget a dose is your best bet to prevent injury or seizures, or injury related to seizures or seizures. Again, children with epilepsy can have seizures or breakthrough seizures, and the treatment, and then we also want to have a plan of what to do if there is a seizure. So like I said, most times the seizures will stop on their own. If it's a big generalized tonic-clonic seizure or a seizure where someone loses consciousness or falls over, you want to make sure that they're placed on their side in a safe place. You don't put anything in their mouth. And if the seizure persists longer than 5 minutes, you give the rescue medication. And that we have several options for rescue medication. Some of them are administered through the nose, some of them are through it's a rectal suppository, or there can be a dissolvable tablet. But it's important that that families and caregivers keep these on them, carry it in their purse and their wallet, keep a dose in the car, so that if a child does have a seizure that persists longer than 5 minutes, you give this medicine. And then if it doesn't stop, you call 911. The other major variable is communicating any intolerances of medication, communicating with your doctor or your child neurologist if your child has had a breakthrough seizure. Often we can attribute it to if they're sick or they missed a dose, or maybe they're outgrowing their dose. As children grow, sometimes we do need to increase the dose of medication. Sometimes we have to change medication. Sometimes, we make our best choice for the seizure type and the child and what we think will work. And then we find, in fact, maybe the child needs a different anti-seizure medication. And some children do need multiple anti-seizure medications. And so it's very important if your child is having seizures or not tolerating their medication that you communicate that with your provider. So disorders or movements that can look like seizures in children are many. I think the definition of childhood is funny behaviors and funny movements and funny feelings and funny behaviors. I think that's a lot of this stuff is typical in children, right? So identifying what is a seizure and what is not a seizure, or what may be something that's not a seizure that also needs medical attention, is really important. So I'm going to go through a few of these. Breath holding spells are common. These are episodes that we see in older infants, like around 1 year of age, and toddlers. And this is when a child is having a tantrum or crying or screaming, they will suddenly hold their breath and pass out. And sometimes they'll hold their breath, pass out, and actually have a convulsion. Their body will shake. And this is, we don't typically treat these with anti-seizure medications. There are treatments for these sometimes. Sometimes we just, we do expect these children to outgrow these, but they're not typical seizures and it's not epilepsy. Fainting is another mimicker of epilepsy and of seizures. And this is when a child will just suddenly slump over and lose consciousness. These can also have a little bit of like shaking associated with them and can be very hard to discern. And so if we suspect that maybe a child is fainting, we sometimes will, it's important that you communicate that with your doctor or with your child neurologist. And we often will have cardiology also evaluate the patient. Facial or body twitching can be a seizure, a type of seizure called myoclonic seizure, but there's also something called benign infantile myoclonus or benign sleep myoclonus. And sometimes the only real way to confirm if this is a seizure or just a benign twitch is to do one of those video EEG studies that we talked about, where you come in and we record it while it's happening on the EEG and confirm whether or not it is or is not a seizure. Reflux in infants is a very common mimicker of seizures. A baby will reflux, whether they spit up or not, it's painful. They'll arch their back, they'll turn red, they'll stretch out their arms, and it can really look a lot like a seizure. And so again, sometimes when we really don't know, we'll have the child come in and do the video EEG and record this as it's happening. Sleep disorders are very common in children and can look a lot like seizures. And sometimes a child with epilepsy will be referred to sleep medicine, and vice versa. A child with sleep disorders come to epilepsy. And so we sometimes work together to sort out what is going on, especially if there's recurrent episodes in sleep. Night terrors are extremely common in toddlers and young children. Night terrors look like the child will wake up, might scream, they might thrash around. And when you go to comfort them, they actually don't seem to be responsive to you. They're awake and they're looking at you and they're talking, but they may not actually answer your questions, or that you may not be able to help them calm down for a while. Cataplexy is a type of sleep disorder where someone falls asleep and then just drops, which can look a lot like a seizure or a lot like fainting. And parasomnias are very common in children, where kids walk and talk in their sleep. So again, sometimes these things, when it's really unclear or they're happening recurrently over multiple nights, it can be helpful to take a home video to show your primary care provider, to show your child neurologist. Neonatal reflexes are normal, and they can look like seizures. Sometimes there's something called a startle reflex or a Moro reflex, and this is something that's present from birth to about 3-4 months of age. And it's when a baby has a sensation of moving quickly or a loud sound, and they do a sudden jerk and their arms stiffen, and this can look like a type of seizure. And so it's important if that's happening but they don't tend to cluster. So if they're clustering or they're actually becoming more intense over time, that would be something to bring to your doctor's attention. There are also movement disorders that are neurological disorders that are not seizures or not epileptic. And these can look like posturing of the arms or legs, or tics or sudden jerks, or can look like, there are also behavioral movements, which are very, very common in early childhood and toddler years and infancy even, where kids will kind of get a little habit, like they'll do a little shudder, or they'll do a little, a sudden movement repetitively when they're excited or when they're tired, or a self-soothing type of movement. These often are mistaken for seizures or need to be evaluated as potential seizures versus normal baby movements. So again, I want to be really clear that some seizures are very clearly seizures, some are not. And if there's ever a question, the most helpful thing you can do is capture a video if it's safe for you to do that, if you don't need to, or to talk to your primary care provider about your concerns. I'm going to talk now about seizures in the newborn period. The fancy medical term for the newborn period is called the neonatal period, and this is birth to 28 days of life. And during this period of time, seizures can be subtle. Newborn babies and neonates tend not to do the full body generalized tonic-clonic seizures. They often do episodes where one side gets stiff or one side shakes. They can also be as simple as a pause in breathing or a color change. And as a person who's had babies, babies do a lot of jerky movements and they do change colors. They turn red a lot, they reflux and they turn red, or they, toot and they turn red. So I don't worry too much about red, but I do worry a lot if a baby gets very pale. I worry a lot if a baby gets very blue around their mouth or blue around their eyes. That's something that is a medical emergency and does need immediate medical attention. Seizures in the first 28 days of life can be potentially very serious, and these may reflect an underlying infection, an infection around the brain, such as meningitis, and potentially indicate an injury to the brain sustained around the time of birth or prior to birth, and also can present as a genetic disorder or a metabolic disorder, which is a disorder in how your body metabolizes energy and glucose and nutrients. And so this is something that in the first couple of days of life, we watch very, very closely for. And the newborn nursery and your pediatrician is watching for it, and the obstetrician is watching for it. And that those first day or two in the hospital, it's on, we watch for this. However, if you go home and you're seeing these events, it's very important that you call your pediatrician right away, or you go to the emergency department. If a newborn is suspecting of having seizures, again, you go right to the hospital, and they will do you would expect the child to be admitted, where we do extensive workup, looking for infection, we'll do an MRI, we'll do an EEG, often a video EEG. And if we don't find a reason, if we confirm seizures and don't have a reason, we often will then do more of a genetic and metabolic evaluation. Treatment for seizures at all ages, neonatal period, infancy, childhood, adulthood, the first line treatment is an anti-seizure medication. We do tend to use different medications in the newborn and infant period than we do in other areas of other times of childhood. Now I want to back up and talk about something that's less scary than epilepsy, less scary than seizures as a newborn. I'm going to talk about febrile seizures. And when I mean less scary, they're less scary to me, but they're very scary to parents. And they're something that are also very common. So these are seizures in the setting of a febrile illness, like a cold or gastroenteritis or the flu. But this is not epilepsy. And this is common. This occurs in 3 to 4 out of 100 children between the ages of 6 months and 5 years of age. And again, this is not a diagnosis of epilepsy because, again, there is a trigger, and the trigger is the fever for these children. These are generalized tonic-clonic seizures. So again, the whole body will get stiff and the whole body will shake. The duration usually is 1 to 2 to 3 minutes, and they usually do stop on their own, but they can last up to 15 minutes. And so again, we always have, if a patient has a history of febrile seizures, we always make sure the family has that rescue medicine on hand to give if the seizure goes longer than 5 minutes. A febrile seizure there should only be one in a 24-hour period. So if a child is sick and they have a fever, and then they have another, and then they have a seizure, and then they have another seizure, and they have another seizure, that's more concerning and does require immediate medical care. Febrile seizures often do run in families, and febrile seizures are diagnosed in children who don't have other known seizure risks, as far as they have typical age development. They don't have a prior diagnosis of unprovoked seizures or epilepsy. They don't have a known reason, like a structural reason or a malformation, a known reason in their brain that they would be at risk for increased seizures. These are very scary for parents. They really are, but they are not thought to be as dangerous. They don't cause damage to the brain. They don't cause or promote or lead to intellectual disability. And while I say all that, you still have to do those safety precautions around water if your child has a history of febrile seizures. Treatment of febrile seizures is supportive, and it's getting your child through the illness, through the cold, through the GI bug, through whatever is triggering the fever. I will say treating with ibuprofen and Tylenol, while often appropriate so your child feels better, is not going to prevent febrile seizures. After a child has children with febrile seizures usually do come to the emergency department after their first febrile seizure. The ER will observe the patient, do a thorough exam, make sure that a source of fever is identified, such as a cold or a regular childhood virus. And if the child is back to their baseline with a normal neurological exam and doing well, and there's not a concern for a more serious infection, they will often discharge that child home. We don't typically treat these patients with an anti-seizure medication, and we don't typically do an extensive workup with imaging or an EEG, unless there's features of it that are atypical from what I've just described. But we do always like families to understand what they are, to know, to call if there is a change in the way these look, to know that there is an increased risk for them with the next febrile illness, and to come to the emergency department anytime they're uncomfortable. I never, even if a child has a clear history of febrile seizures, they're scary for the family, and I always encourage them, if you're scared for your child's well-being, call 911 or come to the emergency department. Now I'm going to talk about infantile spasms, which is a type of infantile epilepsy. This is a rare form of infantile epilepsy, but it is a very important one to recognize, because early recognition and early treatment is really the key to optimizing your neurodevelopmental outcome and perhaps even ultimate seizure control. It's again rare, and we see this in about 1 in 2,000 infants. The age range that this will present is 2 to 12 months, but it's most commonly seen around 4 to 8 months. These seizures are not like as overtly scary on first glance. They last a few seconds. The child will stiffen, often extend their arms, maybe their eyes get wide. Maybe it looks like they do a little bit of an abdominal crunch, it almost looks like a sit-up. But there's not a lot change in color. There's not a change necessarily. There's rarely a change in the level of consciousness, and the baby's typically awake. They can be uncomfortable appearing. The baby may cry, or the baby may look unhappy, but it does not appear. It doesn't look like it doesn't look as like a medical emergency as it's happening. These are often noticed to cluster over a period of time. Maybe families will say, "Oh, they did a few of them in the morning, and then we saw a couple of them at night right before going to bed." They often will be first seen during transitions from wake to sleep or sleep to wake, but they can also happen anytime. They rarely happen during sleep. When this seizure type happens, again, parents will also describe that, like in the week maybe that it starts, they'll say, "Oh, the baby's less interested in interacting, they're babbling less, they may be sleeping a little bit more." Maybe it seems like they've even lost some of their milestones. Like if a child was sitting up by themselves or a child was rolling over, they may do that less or stop doing it altogether. They may be less interactive, less eye contact, less smiling, less babbling, less giggling. They may seem irritable or fussy, sleepy or less sleepy than normal, and less interested in food. This is a video that I want to show you of an infant having infantile spasm. Again, you can see here that this baby is doing, the baby doesn't appear to be in immediate medical distress, but he's having these sort of uncomfortable looking tonic stiffening episodes with his arms, his eyes get wide. And as you can see, it's clustering. He's doing it back to back to back, which is different than what we expect with a startle reflex. So a startle reflex looks a lot like this, but usually just happens once. It's usually provoked by the baby being moved or a loud noise or being surprised by something. And also the startle reflex or the moral reflex typically goes away around 4 to 4 months. And so that's one thing to parents and caregivers to be aware of, is that they're seeing this clustering and they're seeing it happen more. That's something that needs to be immediately brought to your doctor's attention. So what to do if you suspect your infant is having epileptic spasms? One is to call your pediatrician or your primary care doctor immediately. If they're not available or it's going to be days to get in, honestly, the next best thing is to go to your nearest pediatric emergency department. Again, we will admit patients that we suspect having infantile spasms. We'll do a video EEG evaluation. And the EEG is extremely important in this type of epilepsy because it will confirm the seizure type. And in addition to confirming the seizure type, we will see abnormal brain-wave patterns that that are really specific to this type of epilepsy. And that's a pattern known as hypsarrhythmia, but it's a very disorganized background. And that's, in addition to the seizures, a very abnormal pattern. There are many causes of infantile spasms, a history of a brain injury or a malformation, even maybe one that you don't even know about until the time of diagnosis. But there are also over 50 genetic or metabolic diseases associated with infantile spasms. Children with infantile spasms may have other neurological symptoms, including developmental delay, intellectual disability, other seizure types, or other diagnosed neurological disorders. It's very important to identify, if possible, the underlying cause of infantile spasms. So treatment of spasms should never be delayed. Even as we're working up the underlying cause for them, we often will initiate treatment. The treatment of these types of seizures and this type of epilepsy is different than other types of epilepsy and other types of seizures. We often use a high dose form of a steroid. One is an injectable form called ACTH. Another would be high dose prednisolone. There is one specific anti-seizure medicine that we also use called vigabatrin, and this will be initiated in the hospital. And the goal of the treatment is to stop the infantile spasms as well as to improve that abnormal EEG pattern that we were talking about, the hypsarrhythmia. So again, this treatment will be started immediately. And we also reassess at like 2 to 3 weeks to make sure that the seizures in fact are under control and that that abnormal brain pattern is improved. It is important to understand that even if we get very good control and we get the EEG better, these children sometimes do go on to develop other seizure types, and they will need to be very closely monitored for their development and for developing other seizure types or potentially needing other medications down the line. So again, I would like to thank you for the opportunity to talk tonight. And I've covered a lot of information, but again, this is not comprehensive. And I would like to just reinforce, if your child is doing a movement or a spell that you're not sure what it is, take a home video if you can and call your pediatrician or your primary care provider. If your child has a clear seizure, ensure your child is safe and call 911 or go to your nearest emergency department.
Thank you, Dr. Waldron. This has been really informative. I know I learned a lot. While we're, I see no questions in the QA channel, but maybe let's give people a chance to maybe write their question down. And I have a question for you. So I noticed you mentioned triggers connected to the febrile seizures. Are there triggers for other types of seizures?
That's a very good question.
Oh, go ahead.
I'm sorry, go ahead and finish your question.
Yeah, so I guess, and there would be a follow-up question to that, and that would be, are there things a parent can do, like you mentioned, videotaping or something else to document what else is happening around that episode? So maybe if they see a trend, that might be helpful to their primary care doctor, their pediatrician, or their specialist?
So very, very good question. There absolutely can be triggers for seizures. So again, in people with febrile seizures, the fever is the trigger. In a person who has epilepsy, having a fever may also be a trigger. Some forms of childhood epilepsy in particular are particularly sensitive to flashing lights, or what we call photosensitive. So that can certainly trigger certain types of seizures, specifically even the ones we talked about, the absence seizures. Not getting enough sleep can certainly trigger, and a patient with known epilepsy can certainly be a trigger. In a patient who is diagnosed with epilepsy, it's important that the family actually keep a log or keep a timeline, or just keep track of if their child is having seizures, what type of seizures they're seeing and how often. And again, that log is important, that they call us and they let us know what's going on, because again, for the best thing for safety is that we know what's happening and we can adjust medications or change medications as needed.
Perfect. And there are a couple questions coming in, and please audience, if you have questions, please do submit them because we have plenty of time to address them. One thing I wanted to share, and I know you know about these, Dr. Waldron, is we have a wealth of flyer resources on our website. So you can see there on the screen that you can easily get to those pages by going to uhrainbow.org/seizure, and then go under patient resources, and all the different types of seizures, which there are a lot of them. Their great information is there, a lot around safety, a lot around when your children are going to school, those kinds of things. Okay, question number 1. With epilepsy, does the epileptologist do the surgeries if needed, or do they refer to a surgeon?
That's a very good question, actually. So not everybody that has epilepsy needs epilepsy surgery. Not everybody that has epilepsy is a candidate for surgery. But in a child who we think is a good candidate for surgery, it's actually it's a comprehensive team. And so it involves the epileptologist. It involves our neurosurgeon who specializes in epilepsy surgery, Dr. Jonathan Miller. And it is something that is done in a comprehensive sense, in that when we have a patient that we're evaluating as a potential surgery candidate, we actually meet with all the epileptologists in the hospital and in our epilepsy group, and we present them in a formal conference. We work with a neuropsychologist. It's a team approach. The epileptologist does not do the surgery. The epileptologist does the epilepsy evaluation, meaning we do the EEG. Sometimes we do invasive EEGs, and that's kind of beyond the scope of this talk. And we interpret that data. But then again, we meet as a group in an epilepsy conference with both the neuropsychologist, the neurosurgeon, and actually all the epileptologists in our center, to really come up with a consensus of what the right first of all, is the patient a candidate? What are the potential risks? And what would be the approach, and what do we think what would be the potential benefit? And so it is a comprehensive team approach.
Right, because as you mentioned, the ketogenic diet, you also have dietitians on the team.
Again, very much a
child
team
life
approach.
Specialists.
Very much a team approach with we have dietitians who specialize in ketogenic diet. We have geneticists who specialize in epilepsy and other neurological disorders. So while there's, depending on what the child's need is, there is often a team approach.
Okay. All right. And can you describe absence seizures more?
Sure.
Can they occur and the child does respond to stimuli, or is it only occurring when a child is not able to respond to that stimuli?
During an absent seizure, the child will not be responsive, but it can be so brief that it might seem that they're responding. So they can be very, very subtle. They can look, we can miss it. Sometimes the only way to diagnose it's through an EEG. But again, it's a very brief pause, and sometimes the activity, sometimes it's so subtle you just really can't see it. Sometimes it looks like a staring, and parents will describe, they're staring straight ahead, but I can't get their attention, or if I touch them, they don't respond immediately. But again, because they're so brief and sometimes just a couple seconds long, the kid will kind of come to and will seem to respond. The one thing I will say about absence seizures is they're very, very frequent. When a child has absence epilepsy untreated, they are often having many, many of these a day. And so the good news is we can quickly answer this question often with just like a 1 hour EEG. Often they're picked up by teachers because they'll notice like that not only are they staring, but they'll stop writing, or they'll stop typing, or and sometimes kids, they just go right back to their normal activity right after it's over. But sometimes even they themselves will say, I'm missing something. I missed part of the conversation, or I missed part of my lesson, or they can see it. Sometimes also children with absence epilepsy will have a decline in their schoolwork or their academic performance because they are missing big, even though they're only short little couple second episodes or seizures, cumulatively throughout the day, they're missing kind of a big gap. And so that's something that that they can be hard to tell without an EEG.
Okay, and this is a follow-up to that question. The writer is asking, if the EEG is normal, could a child still have absence seizures?
No. I mean, we'll often start with the 1 hour EEG, and if it's normal, that's pretty reassuring. If you're still seeing episodes frequently of staring and pausing, that's again when we would do the longer EEG, the video EEG in our epilepsy monitoring unit, 1 night, 2 nights, 3 nights, and really try to capture one on the EEG. If it is a seizure and it is an absent seizure, we should see it on the EEG.
Okay, great. And this one from another parent, can absent seizures last up to 2 minutes or more?
They can. It's rare. That would be considered sort of an atypical absent seizure, but they can. And there are other seizure types that may look like staring and may look like a pause that aren't generalized absent seizures. They may be other seizure types. So if a child is having episodes of staring and unresponsiveness for up to 1-2 minutes or longer, it's important that that be evaluated.
Mm-hmm. All right.
But again, a lot of kids daydream. And so this is why it's important to sort of recognize that pattern, video record it if you can. One thing that can be really helpful if a child is doing this for a prolonged period, like 30 seconds, 1 minute, 2 minutes, try to touch the child, not just call their name, but actually touch them to see if they respond to you. But if it's happening repetitively or consistently over a period of time, it's important that you see your doctor.
Okay. All right, wonderful. Well, that really satisfies all the questions that have been asked. I'm going to give a little bit of an overview here. If anyone else has another question, please feel free to submit it now. We have a few more minutes, but I would like to say that we do have resources for you. So as I mentioned before, our website has a lot of great resources. You can reach that by going to uhrainbow.org/Seizure. And also, if you're interested in setting up an appointment with a Rainbow specialist, you can call the number that's on the screen, 216-340-8587. And then we also have great COVID-19 resources. And I know, sadly, this is becoming more and more, we're hearing about the Delta variant and other information on the news. And so that's another great resource for our parents that are with us tonight. All right, we did get another question. Does stuttering fall into the same category as seizures? Does head trauma play a role in stuttering?
Stuttering is not typically a seizure. Stuttering is usually a primary speech issue. Stuttering is also very common at certain ages, especially in toddler years and adulthood, and it's something that should be evaluated by your pediatrician. And if there's a history of head trauma and then any new symptom, stuttering, staring, trouble with sleep, that should be evaluated by your pediatrician as well.
Okay. All right, well, that concludes the questions. Thank you so much, Dr. Waldron, for your time and sharing this wonderful information with us. I want to thank our audience as well, and just remind you that you'll be getting an email with the link to the recorded session tonight, and that will come to you in about a week, so give it a little bit of time to get to you. We're going to need to do some post-production work, but we do appreciate your attention tonight, and we just hope you have a great evening, and join us again next time when we have another Health Talk for parents. Thank you.
Thank you.